Um, but that all looks good.
Am I able to talk?
Yeah, feel free.
Okay, great. So I sent you the email coming through. Great. There's some people. I see them. I've never been on presenter mode on this platform before. That's
Okay. Yeah, unfortunately, we won't be able to see people's face. Well, we'll have the opportunity to unmute them at the end, but they'll mostly be communicating with us through chat. But I'll relay all of that to you.
I just got a text that about something really concerning happening right after this. It involves a butcher knife and a patient. So I might have to make a call for 2 seconds before we start, but I will be here. I'm not moving anywhere.
Okay, I'll be doing introductions anyways, so that should
Okay.
take up about 5 or 6 minutes.
Okay.
Thank you to those who are just joining us. We're going to give it about 5 more minutes before we get started with housekeeping. If you have not done so already, please take this time to introduce yourself, your credentials, your practice, or your county in the chat. This just gives us an idea of who's online with us today and make sure that you can access the chat function.
Seven, eight, six, 7, 5, 6.
Dr. Israel, I'm just going to mute you for now. Hi, everyone. Thanks so much for joining us early. We are going to get started in about 5 minutes with housekeeping items and an introductions. Please take this time to introduce yourselves in the chat, include your names, credentials, practice, county, any other information you'd like us to know. This just helps us know who's online and also make sure that you can access the chat function. As you may have noticed, your cameras and microphones are disabled for this webinar just because we are anticipating a larger crowd. So once again, just make sure you can access that chat. I see more and more people have joined. We are going to give it a couple minutes before we get started. I am just going to place a link in the chat. While we wait, if you don't mind filling out this survey, this helps Max do what we do. And it also helps us understand the prescriber landscape in the state of Maryland and just practice patterns across the state. So that helps us tailor our services to you. This is our prescriber survey. We ask that you take it. It is anonymous, and any feedback that you can provide is helpful. So please check for that link in the chat while we do wait a couple more minutes before we get started. And as you may have noticed, our IT specialist is online with us today in case you have any technical issues. Zach's information is in the chat. He included both his email and his phone number in case you have any issues today. And if you have not done so already, please take this time to introduce yourself in the chat, include your name, credentials, practice name, county, any other information you'd like us to know. Just helps us get a better understanding of who's online with us today. All right, the time is now 1 p.m., so I am going to get started with housekeeping. As often happens, I know people are trickling in from lunch, from morning patients, just switching over to the afternoon, so I'm sure more people will join us. But my name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. We are a grant-funded service through the state, and I'll get a little more into our services. But first, I do just want to give you an overview of how you can receive credit for today's training. After today's training, you will be able to access the portal. Well, you should be able to access the portal at any time, but the portal that you use to register for today's event is where you are going to access the evaluation survey, a copy of the slides, other Max resources, and your certificate. Once you fill out the evaluation survey, you then will be able to claim your certificate. And if all of this sounds new to you, if this is your first time joining a Max webinar, if this is your first time using our new portal, don't worry about it. I'll include step-by-step instructions in the follow-up email you will receive after today's training. So look out for that. That'll go to the email that you registered with today. And I'll put my email in the chat as well, so you can reach out directly to me if you have not been receiving those emails. So once again, you do have to be on for the entire duration of today's training. We cannot offer partial credit for this training, and you need to complete the evaluation survey to receive your credit. Here at the Maryland Addiction Consultation Service, all of our services are totally free and include a warm line open Monday through Friday, 9 a.m. to 5 p.m. You can call that warm line with any clinical questions. They can be as patient specific as you'd like, as long as you use de-identified information. Those questions can be anything from struggling with a specific problem with a patient to dosing protocols or patterns you're noticing in your own substance use disorder treatments for patients. It can be anything from screening tools. Any questions you have related to substance use disorders, we are happy to help. So please keep that warm line in mind. I'll put our contact information in the chat in 1 second, so you can also access our website and have that number on hand. That will also be included in our follow-up resources. We also offer technical assistance, which is basically individualized capacity building to practices implementing or expanding office-based substance use services. That could be anything as far as maybe even finding an office space for a new practice that you are trying to open, to more specific things to your practice. Maybe you're already at an established practice and you're noticing people on your team may not agree on the best screening protocols or just protocols in general when it comes to treating substance use disorders. So our technical assistance specialists would come into your practice, hear your concerns, hear your needs, connect you with one of our consultants, and then move forward in helping your practice best treat patients with substance use disorders. Similar to today's training, we also offer free education, free CMEs, free CEUs. Usually they take place around or during the lunch break, and they are a range of didactics, including today's. This is a very new topic for us, and we're excited to present it. But those didactics really range in topics, so please make sure that you look out for our newsletter with everything we have coming up. We also offer echo clinics, which are monthly meetings. We have 3 different rotations going, one for opioid treatment programs, one for maternal health providers, and then one for just any type of practice that you're working in. We call it our substance use disorder clinic, but you can work in any practice and bring cases from your own patient load. You present those once again with the identified information to a group of your peers in the medical community, as well as our panel of expert consultants. You receive feedback on that case, helping with steps to move forward, and then there's a didactic presentation afterwards. So this is a really great opportunity for collaboration, as well as an opportunity for you to present your own cases and get direct feedback that you can take into your practice. And I've mentioned it in bits and pieces before, but we do have our Max for Moms program, which is basically everything we do for Max, but specifically for maternal health providers in addressing the needs of their pregnant and postpartum patients with substance use disorders. So any questions you have about that specific patient population, we do have experts on our team that can help with that. And we also offer mom-specific webinars. We do have one coming out in December. The registration is not live yet, but once again, if you're signed up for our newsletter, you will receive information about that. And if you signed up for today's training, you are signed up for our newsletter. So please look out for that. I also just want to bounce back to those echo clinics because coming up soon, we do have an echo clinic dedicated to trauma-informed care within substance use disorders, and our presenter today is going to be a part of that panel. We will put information about the echoes into the chat, so you also have that on hand, but that registration will also be included in any of our newsletters that come out. And finally, I know I just did a lot of talking, but I do just have a couple more introductions to get through, and then we'll get started with today's content. So as I mentioned, today's presenter is Dr. Benjamin Israel, and Dr. Israel is an assistant professor at the University of Maryland School of Medicine, Department of Psychiatry. Dr. Israel graduated from the University of Pittsburgh School of Medicine and completed his residency training at the University of Maryland Sheppard Pratt Combined Residency Program in Baltimore. He is board certified in adult psychiatry, and he works at a variety of clinical sites focused on consultation liaison psychiatry, emergency psychiatry, and addiction medicine. Dr. Israel runs a trauma-focused outpatient community psychiatry clinic within the university's Division of Addiction Research and Treatment. Dr. Israel is the lead author of a recent critical review exploring trauma-responsive addiction treatment and clinical management, which we can make sure that you have access to. And he teaches and supervises psychiatry and psychotherapy trainees at all levels. He also sees private psychotherapy patients, most of whom suffer with the complex post-traumatic and dissociative syndromes. And Dr. Israel has presented to professional audiences locally, nationally, and internationally on the diagnosis and treatment of complex post-traumatic syndromes. This is our first presentation with Dr. Israel, but as you can tell, he has experience doing this, so definitely tap into him as a resource today. And then finally, we also will have Dr. Devon Gandhi online with us today to help out with any other clinical questions that come up. Dr. Gandhi has been on our consultant team longer, so he's just an extra resource, extra pair of hands to help out with any questions that come in today. And Dr. Gandhi is a clinical professor of psychiatry at the University of Maryland School of Medicine. He's the director of the Addiction Psychiatry Fellowship Program. He is a consultant for MAX. He is the medical director of LifeBridge Addiction Treatment Programs. So you have two really great resources online to tap into for questions. As you may have noticed, your cameras and microphones are disabled, but you can communicate with us via chat today. Today's webinar will be recorded and up on our website within one business week. Dr. Israel, I am all out of talking. I will turn it over to you now. Feel free to get started whenever you're ready.
Thanks so much, Bridget, and to the group for being here. I just want to make sure my slides continue to work. Is this coming up, Bridget, the blank white screen?
Exactly, yep.
Okay. I'd like to start a conversation with the group about trauma in our workplace, the addiction workplace, and more broadly, even about trauma's place in terms of diagnosis, in terms of treatment, and certainly in terms of addiction in psychiatry. Some very, from different disciplines and perspectives, many people have been thinking about this for some time. And I hope that the challenge and also the opportunity that addressing trauma in mental health care and addictions care, I hope the challenge and opportunity we have together to address it differently is more clear for the audience, for you, that you'll walk away with a clearer sense of why perhaps we're not as far as we'd like to be in treating trauma and where we might together be able to go. Tom Inzel was the director of the National Institute for Mental Health for close to 15 years. He recently stated, "We spent about $20 billion at the NIMH during my tenure from 2002 to 2015. During those years, the U.S. suicide deaths increased 30%, and the dailies, which is for disease-adjusted life years, the dailies for mental illness increased 40%, with more people with severe mental illness incarcerated or homeless." So Dr. Insel's discussing the perhaps unique problem in mental health, where in our field we've spent billions of dollars, but our most important, arguably most important outcomes are worse than they were in 2002. We are living in the opioid epidemic now, and we've seen further worsening. But where else in medicine are we seeing this trend? In the modern era of empirical evidence-based study, where are we seeing trends where we're spending these billions of dollars and outcomes in many disorders are getting worse? In psychiatry, we really have a concerning trend to think about. Is there a chance that trauma plays a role in this trend, in helping us understand it and giving us a framework, perhaps, for addressing it differently? This quote is from two musicians, Vic Mensa and Wycliffe Jean, wrote a song early in the pandemic together called Shelter. These are some of the lyrics that say, hospital workers in scrubs with no PPE, but they got money for riot gear. We're dying here. You tell me not to move with my gun, but we got more funeral homes than schools where I'm from. And on the news, all you view is homicides. But tell me why it ain't no trauma units when everybody's traumatized. It's not a secret, in other words, that trauma is pervasive and common, not just with COVID-19, not just with the opioid crisis, but in everyday life, certainly throughout the mental health care system. But in psychiatry, in particular, trauma has been underemphasized in training. Many of you may have noticed, particularly if you happen to be a psychiatrist, that you may not have received much training or any substantive training in trauma disorders, PTSD, and the impairment they cause and how to treat them. But they are so common. We'll talk more about some specific numbers related to this topic, but I hope that this creates a backdrop that we can move from. This talk is called Systematic Screening for PTSD. Is screening the so-called way in to making our practice more trauma-informed in addictions treatment? And what you'll come away from today's talk knowing is, what is trauma-informed healthcare? How is it different from trauma specialty treatment? To get there, we'll need to do a few minutes of so-called trauma boot camp, which you can return for our ECHO starting early next year to dive in a little bit further. We'll need to know what trauma is, and we'll need to know what makes trauma-informed healthcare different from trauma specialty treatment. And you'll also walk away with one highly regarded, evidence-based, brief way to assess all your patients for PTSD starting this afternoon or starting tomorrow. You'll walk away knowing how to do that. I have no disclosures to make. I want to acknowledge that approaching the topic of trauma, which I've been doing essentially full-time for since 2016, it tends to be activating. I've found it that way myself. It tends to expose our blind spots, and I want to acknowledge my own, and perhaps through our interactions here today and maybe going forward, for those who would like to participate in our ECHO, I'll hope to learn from you all more about my blind spots and to learn how to approach this a little bit better. Here's a example of a case that I see, someone I saw at our downtown outpatient addictions clinic, Donna F., 46-year-old, significantly African-American woman. She presented depressed. She had vague suicidal thoughts. She has an abusive partner, intimate partner violence for some time. She was a little bit nervous to see me, as psychiatrists had pathologized her symptoms before, particularly white psychiatrists. She had a history of schizoaffective disorder, bipolar disorder, cocaine use, and opioid use disorders, and benzodiazepine use disorder. She recently experienced skin infections, asthma, hypothyroidism, autoimmune hypothyroidism. She had attempted suicide by overdose using sedating substances. She'd also engaged in unsuicidal cutting, not recently before I saw her, but that used to be frequent for her. She had her GED from finishing high school. She was currently unemployed and staying with a friend, but perhaps a few days from not having a place to stay at all. On review of systems, she was certainly depressed. She also described hearing voices since middle school, and those voices got loud. They sounded like a crowded restaurant in her mind, she described, when she was anxious or agitated, and she was quite anxious, in part because of her housing insecurity at the time we met. She described having manic episodes, quote unquote manic episodes, but they wouldn't last more than a day or two. That is why she had been diagnosed with bipolar and schizoaffective disorders in the past. She described flashbacks, including so-called body memories. So she experienced sensations in her stomach, and smells that reminded her of traumas she'd experienced from a young age, including sexual traumas. She had a constricted affect, so she showed emotion, but not as much as a person typically might. She was goal-directed. She wasn't disorganized in her thinking. She described hearing auditory hallucinations and the restaurant in her mind experience, but she didn't seem distracted by it and said she had felt used to it and knew how to block out the voices from a young age most of the time. So that's Donna, and we'll return to her case at the end of our talk. So we'll need to define trauma and trauma-related disorders today to clarify what trauma-informed healthcare means and how it's different from specialty treatment. We'll describe two important ways in which addiction and trauma disorders can interrelate and impact one another. We'll describe one well-tolerated, evidence-based, brief screening tool for detecting PTSD early in outpatient treatment. And we'll talk about a way in which PTSD screening can help build a foundation for improving trauma-informed practice more broadly in our work in addictions. So a little bit of history, you might recognize these are pictures from fairly early in the Vietnam War. We have American soldiers on the left and actually that's a Viet Cong captured soldier on the right. And this is an important time in the history of the trauma disorders field, because at the time these pictures were taken, there was no such diagnosis as PTSD. We had already knew about trauma impacting people's functioning. About a quarter to a third of all combat casualties from World War II and World War I were due effectively to PTSD. World War I, they called it often shell shock. World War II, combat fatigue. And if you rewind even further back to the 1890s, Sigmund Freud's first theory of the mind was a trauma theory called seduction theory, which was showed through clearly in the cases he was describing at the time as he was pivoting from neurology into what became psychoanalysis. Freud abandoned that theory and effectively forbade his followers from discussing trauma in favor of repression theory and the Oedipal complex as a way to describe so-called fantasies about boundary violations. is being attributed to fantasies about power dynamics in the family. Psychoanalysis ruled psychiatry for the next 70 years, which is why this is important. And that legacy of effectively psychoanalysts, leading psychoanalysts, being literally threatened by the leadership not to look carefully at trauma, led to a situation in the Vietnam War where finally cameras were led onto the battlefield. And it's for that reason that the press made it in mass into the war zone, that politically it became undeniable. The issue of trauma became undeniable and necessary to finally inscribe into the psychiatric nomenclature. PTSD arrived in 1980. When it arrived as a syndrome to describe the classical symptoms of trauma that clinicians were seeing in Vietnam War veterans. It did not do much to describe symptoms of childhood trauma, which turns out, as we will see, to be more common than war trauma, and also very common at all major points of clinical care. So what we got in 1980 was an improvement, but it did not describe the full picture, which we see in our clinics. So what are these syndromes? PTSD requires something called criterion A in the DSM, which is essentially exposure to a life-threatening event, and that would include a sexual assault, or witnessing such an event, or witnessing evidence of an event, such as a detective looking over photographs from a gruesome crime scene. It involves intrusions. We call them often nightmares and flashbacks. Intrusions are not just visual and auditory. As we learned in Donna F's case, they can involve all five senses, emotional flashbacks, behavioral flashbacks, and other kinds. There's phobic avoidance of cues of people or places that remind the individual of the trauma. And these symptoms need to create a significant mood disturbance and involve a heightened sense of threat and hypervigilance. So these are the basic criteria for PTSD. Since 2013, we've had another diagnosis, a subcategory of PTSD called the dissociative subtype of PTSD. So that includes symptoms of PTSD and so-called simple symptoms of dissociation. So that's depersonalization, where a person feels disconnected from their body, like they're watching from outside, or they've sometimes feel shrunk inside their body and physically numb. And the other is derealization, where it's hard to tell the difference between something that happened to me or something I thought about or dreamed about. It doesn't seem to be important clinically whether someone depersonalizes or derealizes or both, but that's PTSD dissociative subtype, and the symptoms tend to be more complex, difficult to treat, and impairment tends to be higher in the dissociative subtype. And in Europe and the rest of the world, really, we recently have the addition of something called complex PTSD, which is distinct from the DSM definitions. So that includes PTSD and something called disturbances of self-organization, which involves three categories: emotional dysregulation, so mood swings, problems with relationships, and negative self-concept, which I translate as significant shame, similar to the guilty and worthless feelings criteria of major depressive disorder. It does not involve detachment to dissociation. Complex PTSD is, we're seeing more and more now in the lay press and also in epidemiological research. It's being researched extensively, particularly by investigators in Europe, some in the United States also. So we're seeing a diversification of our nomenclature in the last decade. The impacts of PTSD, so increased risk for major psychiatric problems, including depression, suicidal behaviors, impaired functioning in relationships, also at work, and certain PTSD symptoms seem to strongly predict opioid use among the use of other substances. In complex trauma, we see increased comorbidity, so increased prevalence of other psychiatric problems, increased rates of impairment, more difficulty treating. So among the patients we see in healthcare, across healthcare, this is a chart we actually recently had accepted in a paper that's now in press at the Journal of Dual Diagnosis. This is a survey of every study ever done, to our knowledge, looking at comparing the point prevalence of PTSD in a group of patients. So this is patients, this isn't the general population. These are people seeking treatment, comparing the point prevalence and the diagnosis rate in the charts. So we have addictions at the top, and what you find is essentially a quarter to a half of patients who seek treatment anywhere. Addictions, inpatient, outpatient, CMHCs. I included forensics at the bottom. But across the board, we have about a quarter to a half of patients seem to meet criteria or meet criteria for PTSD. And we have a chart diagnosis rate of about 2 or 3% on average. So it's anywhere from 0% to 7%, and that was in one study in outpatient psychiatry. Most of these numbers are 0 to about 4 or 5%. So this is really a remarkable difference in about 22 different studies, if I counted this right before our talk today. In different countries, largely in the US, but not exclusively. There's something going on, as I proposed before, in psychiatry, where many psychiatrists are not receiving the training they need to detect this common diagnosis, more common than bipolar disorder and schizophrenia combined, causes significant impairment and impacts so many of our patients. By the way, while the point prevalence is about a third at any given moment, the lifetime prevalence is approximately double the numbers you're seeing here. So someone may be sub-threshold some of the time and not show up on a screen like this. But this is clearly pervasive at every point of care, and anything we can do to improve our detection can help us build a framework for treatment, perhaps in a different way than what we were trained. The study of trauma and trauma-informed care began about 20 years ago when trauma-informed care was coined in a famous book in 2001. And building an evidence base showing that trauma-informed care helps has proved devilishly hard. It is hard to study outcomes of key outcomes from large groups, cohorts of patients in parallel to staff that we're attempting to train to implement certain procedures. So that is what our ECHO will largely focus on. How do we help patients and help staff at the same time? The study of trauma-informed care has shared something of a parallel existence with the study of the social determinants of health. Social workers, who I hope are in our audience, will have heard about this a great deal. The social determinants of health essentially describe the conditions for life and living. And there's a hallmark paper from the mid-1970s by McEwen and colleagues. It really helped break open this field. If we study the conditions of life and living, why might that be important? And by the 1990s and early 2000s, it was taken as dogma that the social determinants of health were going to be important to measure and assess. Before the 1990s, it was actually somewhat controversial. We're years behind the progress that the social determinants researchers made. But here's a keynote study. So McEwen and colleagues studied the death rate from tuberculosis from 1848 until the early 1970s. And this is an interesting study for at least a couple of reasons. So first, there was no effective medical treatment for tuberculosis until the late 1940s, when streptomycin was discovered. Actually, the first modern double-blinded placebo-controlled trial focused on streptomycin and its use for tuberculosis. Streptomycin is so toxic, it's almost never used anymore. And you can see that when streptomycin arrived, the death rate from tuberculosis went down to zero, or very close to zero. But something very interesting happened from about 1848 to 1948. The death rate from tuberculosis dropped 83%. 5 out of 6 deaths were no longer happening from tuberculosis without any effective medical treatment. Something else must have been happening. Is it possible that tuberculosis became more lethal on its own due to natural reasons over that century? That is possible, but for various reasons, the author concluded it would be very unlikely. The reasons that the authors proposed, well, they didn't have the language yet, effectively were the conditions for life and living changing dramatically as the Industrial Revolution matured. Living conditions, housing conditions, increased living space in England, and especially improved nutrition and education became available to the common people. Those were the most important reasons that the authors identified as contributing to the 83% decrease in death rate from one of the most deadly pathogens at the time. So essentially, they argued that the social determinants of health, the conditions for life and living, effectively functioned as a form of medicine. Streptomycin finished off the remaining 17% of mortality, but mortality had already dropped more than 80% by then. Really remarkable. This type of finding has been replicated countless times. Here's just one example where we see a more recent study, 2013, family income predicts your risk for having a activity limiting chronic disease. And this is a powerful correlation statistically. So the social determinants of health remains alive as well as a research focus and public health focus. And as we think about trauma and trauma-informed care, in parallel with the social determinants of health, if the social determinants are the conditions for life and the conditions for living, we can think of trauma as the conditions of our relationships and the conditions of relating. And that may give us a helpful framework as we think more specifically about trauma-informed care, trauma-informed healthcare. So let's dive into a little bit of trauma boot camp. Dive further into it. What is it fundamentally? We have a sense of what PTSD is, PTSD with dissociative subtype, complex PTSD, but what fundamentally is it? How do we define trauma? What do all these pictures have in common? So here's a child, civilian caught up in Vietnam War. This is a famous child custody case, Terrell Peterson, who tragically died while in custody due to ongoing abuse. This is a scene from Baltimore, near where I live. Very exposure to all kinds of difficulties in the city, being raised by a parent who is actively using substances, natural disasters, fires, medical trauma. This one's natural disasters. This is actually an art display that I liked. Forced silence, sexual harassment. This is a mural from India. Forced silence, child sexual abuse, military traumas, other. How do we define this under one rubric? And furthermore, are there other kinds of trauma that usually don't show up on slides like this one? All those pictures represent what we often call big T trauma, something that's so overwhelming it blows our mind, and we can't put it away. We can't turn it we can't turn it into part of our narrative history. It keeps popping up like it's happening again. For people who experience many of these events, however, what often we find is that under the surface, and we may not have to look very far, there are other kinds of traumas that impact them at least as much, if not more. Often, these are described as so-called little t traumas. Any one event, like a microaggression or experience of stigma or experience of discrimination, experience of bullying, coercive control. I'm seeing some comments pop up that the presentation isn't showing up. Is it worth pausing, Bridget, to make sure we are okay?
It still looks great on my end. I do encourage people who are having issues to message our IT specialist, but Dr. Azriel, you can keep going.
Okay, thanks. In people who describe multiple big T traumas, for example, a patient presenting to the ER, saying for a rape kit, and the doctor asks, well, has this happened before? And the patient says, sadly, yes, this is the third time in a year. There's a tendency among some healthcare workers to have thoughts or make statements, subtle statements, implying it's the patient's fault. Tragically, that's still common in every setting I've ever worked. And I suspect it has to do a lot with the training gap that we see, not just in psychiatry, but perhaps most of all in psychiatry, based on my experience in conversations with colleagues from other disciplines. What we see as a relationship is that many patients with big T traumas are more vulnerable to being re-traumatized, in part because of how they have internalized how to relate to people from a very young age. And often, if you work with someone with multiple big T traumas in psychotherapy, what you find are it's not so much the cataclysmic events that make it difficult to make progress in therapy. It's the little t events. It's that patient's expectation that I'm going to betray them some way, subtly, through a medication dose adjustment, through the words I say, through trying to subtly control them over time. It's these little t events that become the most challenging and important issues to deal with over time in long-term treatment of patients with trauma. And often, what's under the surface of the iceberg are hundreds or thousands of little t traumas that are very difficult to quantify in a conversation or on a standardized tool, but add up to a very large impact. We can think of little t trauma as being like resembling a death by 1,000 cuts or 1,000 pins. In many of these situations, double binds is a situation, a little t trauma, where a person is stuck in a very difficult adverse situation, and they're damned if they do, and they're damned if they don't, and there's no way out. So a child growing up in an abusive house may say, well, at the dinner table, I was scolded if I didn't eat my food, but I was told I was fat and obese if I ate too much. And if I tried to leave the table, I'd get hit. So that's a common example of a double bind, right? We see this in community health in different ways. In adults with children have to make incredibly hard decisions. Do I pay my rent or do I pay for my heating? And there's no way out, right? Which is worse, right? So these double binds often start in childhood, and our society contributes to them being recreated in different ways. In complex trauma treatment, long-term therapy, patients have often an impulse to try to create these double binds, these difficult situations in the therapy. And it's exposure to that and working through them that can be so helpful. Defining trauma is hard. You can think of dance as an analogy. How do you define dance to someone who doesn't know what dance is? If an alien civilization came and they opened our dictionary and they didn't know what dancing was, what they'd find is dancing is moving one's body rhythmically, usually to music. And we all know that that would tell them exactly nothing about what dancing is or what it's like. in the experience of dancing is very personal and depends on all kinds of factors, including a person's emotions and experiences at the time it's happening. We hear all kinds of quotes in pop culture about trauma. A famous traumatologist, Dr. Bessel van der Kolk, was quoted in the New York Times saying, trauma is an event. If it blows your mind, it leaves you helpless and terrified. A mentor of mine once said, trauma is something that's so painful you can't learn from it. I thought both of these were quite memorable. The dictionary, the same dictionary, Merriam-Webster, describes it in an interesting way. Trauma is a disordered psychic or behavioral state resulting from severe mental or emotional stress or injury. It also says, according to the dictionary, if you're upset, you could say you're traumatized, which is how often in everyday life people really do speak that way. Is that helpful clinically? I would propose probably not. But if someone says you're traumatizing me because you're making me upset, they can point to the dictionary and they would not be incorrect according to the print. I was surprised to find that doing research for this talk, but it's there. We talked about DSM's criterion A, exposure to actual or threatened death, serious injury, experiencing, witnessing secondhand, like a detective learning of the traumatic event, or exposure to aversive details. That's the detective work. There are other definitions. There's a similar definition in the ICD. There's a similar definition, actually less detailed in the ICD, less detailed by the American Psychological Association, and the list of definitions go on. Most of the definitions don't capture some element of what we know from our experience and from working with patients. Obviously can be traumatic, especially those little t traumas. Typically, they're so important clinically, and they cause symptoms clinically. They cause PTSD. We have research coming out, especially in the last few years, especially in the LGBTQIA literature, showing that discrimination and stigma cause PTSD, even if they don't meet so-called criterion A parameters, because of how the criteria are written. The definitions that we have available also don't really tell us the difference between trauma and adversity. And if we Google image search the word adversity, we see very different pictures. You see a lot of images of plants growing through cracks in the concrete. You see a lot of pictures of, it's usually a white man pushing a rock up a hill, something like that. But there's bias baked into these, and there's also a positive tone that you see with adversity versus trauma. So what's the difference? The best definition I'm aware of, and the one that I use in my work and in my research, comes from SAMHSA, Substance Abuse Mental Health Service Administration. And they famously coined a system called the 3 E's for defining trauma. The first E is an event or a series of events or set of circumstances. That has to be part of trauma. If a bad thing didn't happen, little t or big T, then we don't have the first E and we can stop. Second, that event has to be experienced. So if I was in a coma, I probably didn't experience it. I might have medical trauma when I wake up from the coma and find all kinds of things happening to my body. But if I don't experience the trauma, I don't meet this definition. And finally, that experience of the event must leave lasting negative effects on my functioning and mental, physical, social, emotional, or spiritual well-being. Those are the 3 E's of trauma: event, experience, and lasting negative effects. So please notice that SAMHSA doesn't try to dictate what those lasting negative effects are. Okay, we can start to formulate different kinds of reactions to events, experiences, and lasting negative effects as traumatic, even if they don't technically fall under that classical Vietnam War definition that we still use for traditional PTSD. So one example we'll talk more about in the boot camp, in the ECHO boot camp, is the syndrome that we often call burnout. from difficult, challenging experiences in relationship with one's workplace. Burnout and compassion fatigue involve one or more events, often small events, microaggressions, and difficulties in the workplace environment that are experienced and leave lasting negative effects on a person's ability to do their job. We can start to think of trauma more broadly and in a way that we can structure an organizational approach, even a public health approach, using a definition like this that is clear and tells us that if you have an event and an experience but not lasting negative effects, perhaps it's adversity and not trauma. So there, now you all can define trauma to patients or in other parts of your life if it's helpful, using a much more what I propose is a durable technique. What I'm seeing now, I'm glad to see now, is this definition is showing up more and more in the top by the top raters in the field about trauma. We see this in addiction. We see that exposure to trauma, this is exposure to technically ACEs, adverse childhood experiences. Now we know that adversity is different from trauma, but it happens to be easier to study. So we have the adverse childhood experiences landmark study that we'll talk about a little bit, showing in this case in about 8,500 adults in California, your risk for initiating drug use goes up to close to 10 times before 14 years if you have an adverse childhood experiences score of 4 or 5. Okay, the maximum score is 10, but a high ACE score, and we'll talk more about that in a moment, is a 3, 4, or 5. You see the risk for starting drug use increases very quickly, at not an ACE score of 7, 8, 9, but at an ACE score of 3, 4, 5. For all age groups, the risk goes up at an ACE score of 3, 4, 5. This is a recent meta-analysis of all the ACE studies that had been done at the time, and the adverse childhood experiences study and subsequent studies looks at people's exposure, population members' exposure to any of 10 categories of childhood adversity. These are divided into 3 categories. They're all household dysfunction categories. So physical abuse, sexual abuse, emotional abuse, and then household dysfunction, such as a parent going to prison or witnessing one parent beat up another parent. And the more yeses you have, the more experiences you've had, you get 1 point, not for the number of traumas or adversities, but for the number of categories. And what you see is your score from 0 to 10 predicts going higher on the ACE score. It predicts your risk for tobacco use, predicts your use for alcohol problems, for illicit drug use, among many other outcomes. And this is as of 2019, a synthesis of all the studies ever done. Suicide attempts, violence victim, also many medical problems that we'll talk more about, can be predicted by your exposure to trauma and adversity. We know with confidence that trauma history predicts increased risk for substance use disorder, and that a diagnosis of a substance use disorder predicts increased risk even if you don't know anything about a person's history. Simply a diagnosis of a substance use disorder, especially if it's a sedating substance, such as alcohol, benzodiazepines, and opioids, your risk for trauma history escalates immensely. So if someone has alcohol use disorder, risk for trauma, if you know nothing about their history, is more than 20 times the risk of someone without alcohol use disorder in the general population. One question that we're still looking to understand better is, how do PTSD symptoms on that moment-to-moment, day-to-day level, how does a person's level of PTSD symptoms predict substance use disorder outcomes? And we're starting to learn more about that. And it looks like certain symptoms, particularly hypervigilance, may predict certain important outcomes like overdose risk from day to day. So this is, we're working on building the evidence base. We're not as far along as the social determinants research area, but we're working on it. Looking at the current state of evidence on trauma-informed specialty treatment, trauma-informed care, it sometimes looks like there are more open questions than answers. And that's because there probably are. As I mentioned, hypervigilance and flashbacks may predict relapse, but we don't know the specifics yet. Patients with substance use disorder and dissociation together seem to be harder to treat, and that makes intuitive sense, but the data is still being investigated and interpreted. We've had some surprising study results too. For example, if we only try to treat PTSD as a syndrome without looking at key experiences, perhaps like these ones at the top, the hypervigilance and intrusions, treating PTSD in a blanket, in a broad sense, does not seem to reduce substance use outcomes, which I thought was very surprising, but that's the data we have at the moment. However, we do see that treating PTSD and substance use disorder together does seem to improve outcomes. So there really are some important open questions here. All of these questions that we're looking at on this slide relate to the specialty treatment of trauma. These are different from trauma-informed healthcare, which is what we're here to focus on today. It's important to have a sense of what the difference is between specialty treatment of nightmares, flashbacks, phobic avoidance, intrusions related to trauma, and an organizational approach to addressing trauma, not only in patients, but among ourselves and our colleagues who are exposed to what the patients bring in the door.
Dr. Israel, I just want to let you know that we have about 10 minutes left. There haven't been any questions in the chat yet, so feel free to keep going for about 5 more minutes.
Okay, thanks. So the adverse childhood experiences study showed us that we see this trend increase risk for negative outcomes across not just psychiatry, but behavioral outcomes like suicide attempts and sexual promiscuity, infectious disease, diabetes, and many other medical problems. So exposure to adversity and trauma in a way mimics, this is a picture of the famous cosmic microwave background taken about 300,000 years after the Big Bang. And those slight changes in color, this is actually about 1,000th of a degree Celsius different in the dark places versus the bright places. Those slight differences at the beginning predict massive changes in the structure and shape of the universe and galaxies clusters billions of years later. And trauma plays an analogous role, perhaps not as grand a scale, but an analogous role in the lives of our patients. Does it hurt to ask someone about trauma history? Well, it seems that if you do it carefully and you show good manners, it does not. If you do not approach trauma history questions in a thoughtful and polite way, it might activate patients needlessly. But what we understand, based on the synthesis of numerous studies, is if you ask carefully and if you don't try to probe with someone who's not looking to talk about their trauma history, you're able to get a sense of someone's exposure to trauma without having to dig, and it will not hurt them. So we spoke about what PTSD and complex trauma disorders include diagnostically and the impacts that they can cause. The more complex the syndrome, the more impairment we expect. And we know that these disorders, that PTSD is very prevalent, and to our knowledge, in every study to our knowledge, the chart diagnosis rate is very low, especially compared to the point prevalence. We also know, and this is one reason complex PTSD is so important, we know that complex PTSD at many major points of care, and we could only fit a few of the studies, there are actually at least double these. Complex PTSD is the norm. It's more common than PTSD at many different points of care, including not just clinical sites, but outpatient and inpatient clinical sites among refugees. You see often double, sometimes more than double the prevalence of complex PTSD compared to so-called simple PTSD. And this is one reason why our 1980 diagnosis of PTSD, which is still very close to what we have in the DSM-5, doesn't get us perhaps far enough. So we've reached the end of a kind of mini boot camp. There's much more we can talk about when we have more time in ECHO. Let's move to trauma-informed healthcare, where we can start to look at the difference from specialty treatment to trauma and trauma-informed healthcare. Here we have evidence-based treatments, medications. We have an alphabet soup. It sometimes feels like an alphabet soup of different therapies. TFCBT, EMDR, psychodynamic psychotherapy, some forms of DBT, and many others. And trauma-informed healthcare, which really is looking at organizational approaches that are much harder to measure in a trial. Often we see definitions of trauma-informed healthcare like this, saying trauma-informed healthcare is an overarching structure, and I'm going to move a little more quickly, that impacts both clients and providers, not just clients. So trauma-informed trauma specialty care is only focused on treating symptoms in clients and patients. Trauma-informed healthcare has to include the whole team, because we are working together, and we, being human beings, we will experience aspects of our patients' behaviors and even their emotional experience, whether we want to or not. There's no perfect PPE we can use to prevent that. SAMHSA offers a wonderful functional definition of trauma-informed healthcare as having 4 pillars. And this is what I propose for our purposes, and also in my research. This gives us a framework for really building a trauma-informed healthcare, these 4 pillars. First, we understand what trauma is. Well, now we all do. We have a definition for trauma, and we know there's big T and little t, and there are other dimensions that we can talk about in the ECHO that may be very helpful. What are trauma's impacts on the patients? What do they look like? Can we recognize the signs and symptoms, not just things that patients might say or how they respond to a screen, but what behaviors might signify trauma? How do we respond to trauma? What kind of help, verbally and with medications, can help? And finally, the last piece is organizational. Resist re-traumatization. What are the policies and procedures that we need to systematize in our organization to help us resist the pull that trauma symptoms exert every day from our patients? And we can break these down to smaller compartments. We can break them down, and this is just to give you an idea, into even more. We can operationalize this in a very detailed way. But this is where most trainings start. Most trainings, if you've been to one, starts at, what can we do? Are we going to prescribe a medication? You can do some a CBT exercise. And really the problem with this is it's like learning how to figure skate backwards on one foot in your first lesson. In other words, when you start to look at what responses for trauma really are meaningful, it is hard to get mileage out of them unless the person delivering those responses can recognize trauma and they have a fairly reasonable understanding of what trauma even is. Otherwise, these responses simply will not go very far, and we won't recognize trauma well enough to respond the way we need to.
Dr. Israel, we are going to need
Yes.
to stop. We're just about at time. I do just want to say we will answer these questions. They'll be included in the recording. Thank you all. If you do have a hard stop at 2, please feel free to log off. Thanks for joining today. Look out for an email with the slides, next steps, and any other information from Max. As always, we encourage you to put questions into the chat throughout the training, but we will get started on the questions we have here. If for any reason we don't cover all of these questions, we will follow up with you directly and count it as a Max consult. So that's a great way to get to know our services. But I'll get started with this first question, and please let me know if you prefer to follow up with this person one-on-one. But the first question is, do you think decriminalization of drugs will lead to decreased trauma?
Yes, I think the decriminalization is one of the most important public health policies that's been proposed, particularly the decriminalization of low-level substance possession, substance use. And we've seen this, as many as you might know, in Portugal, probably most famously. And it has helped, and it hasn't been implemented on its own, but in concert with a number of other trauma-informed, systematic policy and organizational changes. And what we've seen is that the benefits of harm reduction treatment for addiction go up in concert with criminalization going down. Also, there are obvious parallels in terms of criminal justice responses and earlier experiences of abuse and perpetration that we can completely stop if we, in many cases, um, if we don't punish so many people, and we all know clearly from the evidence that people from minoritized populations are targeted by the criminal justice system much more than people who look like me, frankly. And we can do a lot of good by stopping criminalization, both for harm reduction outcomes and for reducing exposure to subsequent trauma and victimization. I will not comment. I will not include social commentary, but I hope that answers the question.
That is great. Thank you. Our next question is, what do we know related to experiences of PTSD among non-treatment seeking samples, particularly of women who use drugs?
The prevalence of PTSD is in non-treatment seeking samples. It also seems to be high. So we know in population studies that the prevalence of PTSD is lifetime prevalence 3.5%, about 7%, I meant. Point prevalence in the population is 3.5%. And that is more than bipolar 1, bipolar 2, schizophrenia, schizoaffective disorder put together. Okay, so if we think about how often we may see those other disorders, bipolar and psychotic disorders in patients' charts, how often are we seeing PTSD in proportion to that? And in most places, I've had a chance to see PTSD is rarely diagnosed, not diagnosed nearly as much. And we need more data about that. I'm not aware specifically about what the data says about women who use substances who are not seeking treatment. But the general population data is very clear that PTSD is common and that it is more common that if someone is using substances, especially sedating substances, there's a much higher risk that they also have trauma and PTSD.
That is, thank you so much. We will say for now that this is our last question. I know there are a couple others, but they seem to be very common, so I'll address those in a second. But this question is, what suggestions can you offer for us to build sustained capacity to support clients who are impacted by trauma? And this attendee also requested any trainings or books that you can recommend.
Okay, thanks. Thanks for that. And what was it capacity? Can you say, repeat, please, Bridget, the capacity among the patients or among the healthcare system?
It looks like they just said capacity to support clients who are impacted by trauma. So I think
Okay,
that was just
great. So there are two steps. So the first what we were going to get to is there's a brief tool that's freely available online called the Primary Care Screen for PTSD for DSM-5. You can find it online in a Google search in a few seconds, and it is simple, accurate, and fast. It is shockingly accurate. You can do it in under a minute. Okay, and that is one way to help someone know that they meet criteria, and we can use an official tool to show that this person is not alone in their symptoms. So that's one tool you can use. And when we think about supporting someone and helping them cope with their symptoms, evidence-based treatments look at these fancy therapies and treatments that often are for specialists, especially psychotherapy and prolonged exposure and TFCBT and certain medications. And that's why we refer people. But really, where we start isn't there. Not for any disorder. We start with psychoeducation and treating people with dignity. If someone's diagnosed with strep throat or HIV, we don't hand them a prescription right away for antiviral treatment. We teach them what they have and what they don't have and what it means, and we help them absorb the impact, and they may have many questions, and we attempt to answer them. And one of the most important things that we can do is teach the patient not at an expert level, but at a basic level, that these are symptoms, they can be treated. It doesn't mean there's anything wrong or defective or bad about you. In my professional view, it doesn't mean you've done anything wrong, and they can get better with treatment. You don't have to start treatment right away. We can help you think about approaches for that. But that is where treatment starts, just like any other medical or mental health condition. Our evidence base really doesn't emphasize that, unfortunately. Our evidence base is designed for essentially the private practice model, often out of network private practice therapy and medications for trauma. And in large health systems and in clinics and in addictions work, there's a huge opportunity for us to really flesh out the rest of this pyramid by providing psychoeducation and making a point at work and with our patients to remember the humanity of our work. And this was part of the paper we put out last year. Bridget and the wonderful Max staff can make that available. But we can look at dignity and we can look at shame and shame reactions in systematic ways that we can implement tomorrow at our clinical site. We can use fact sheets for PTSD, which we're developing for our echo sessions here at Max, in systematic ways to help teach our patients. That's where treatment often starts. And what we know about treatment for trauma is that it's the quality of our relationship with the patient that is the best predictor of outcome. It's not the quality of the medication. It's not the acronym of the therapy. It's the quality of our therapeutic relationship and alliance. So I really appreciate that question, and I hope it starts to get at what we can build out further in our Echo series.
Thank you so much, Dr. Israel, and thank you and Dr. Gandhi both for being online for fielding these questions. I am going to follow up with the two of you directly because we have a few extras. Dr. Israel, throughout your presentation today, we were getting a lot of different comments outside of questions that I think you would love to read. So I am going to pass those on after today. But for those of you who are still online, this recording will be available within one business week. We really appreciate you taking the time this afternoon to join us, and please look out for more information about our trauma echoes. We're super excited to launch those soon. Once again, Dr. Israel will be on those. Dr. Gandhi, I believe you will be too. Correct me if I'm wrong. Yep, Dr. Gandhi will be on those as well. So once again, thank you all, and thank you to both of our presenters for being online today. And please reach out with any other questions. Keep us in mind as a resource.